Great. So let's begin. Welcome everybody. Thank you for joining. Others will join along the way, but I want to not take too much time from Dr. Ramaswamy and her talk. So just to start out, welcome to, this is the 14th, I can't believe it, but 14th annual HARC meeting, Health Literacy Annual Research Conference. You could say, hey, why is the L silent? Why isn't it HLARC? But, you know, I just didn't think that sounded very good. And so you're in the private joke now, the L is silent in HARC, yes. So this is the 14th year, unfortunately virtual again, with the vagaries of the pandemic. Maybe over the course of the next 30 years, the COVID will go away. I don't know exactly when. But this year, the conference is sponsored by the journal Health Literacy Research and Practice, which is my honor to be the editor of that as well. So here are a few housekeeping points. One is to please look for a link for evaluations that will come right after HARC. HARC is today and tomorrow, but you'll get an evaluation link as well. There's also CEs that was posted as a question in the chat as well already, but yes, there are also going to be continuing education credits that are available for people. The link for that will come as well, probably in the same email as the evaluation email. Each session is run as its own Zoom link. So the sessions will finish. You have to go back to the live event page of the conference and click on the next session, click on the next Zoom link to keep it going. And please remember to go visit the posters as well. So you can put questions in the chat or the Q&A. I'll be monitoring there, and hopefully we'll get to have some conversation with Dr. Ramaswamy at the end of her talk. Unfortunately, because of Zoom, we just have to run it like that. So having said that, I'd like to welcome you, Dr. Ramaswamy, to give the kickoff keynote today. And let me just tell people a little bit about you by way of introduction. She serves as a professor of population health at the University of Kansas School of Medicine, and has written a lot in the space of behavioral and systems levels and interventions that address women's health and cancer prevention, and in particular in the context of mass incarceration and the carceral system. I would say there's all kinds of things in your background that are very impressive. But what's extraordinary to me is just the fantastic amount of mentoring that you've done. The fact that you have over 200 mentees across the whole stage, the whole span of educational development, from high school students to junior faculty, is just extraordinary. It's really fantastic, and so I'm really looking forward to hearing your stuff. So please take it away.
Thank you so much for that introduction. I will say teaching is my single favorite thing. So I don't know if that'll get reflected in this talk, but at the end of the day, I make health education intervention. So that is a version of the kind of teaching I do. So it is truly my pleasure to be here. I hope that you find this enjoyable. I'm so excited to talk about this because it's sort of my two favorite things. One is where empirical data tells you a story that actually illustrates a theory or shows a phenomena happening in society. And that is sort of this construct of health literacy. And the second thing is when you can use empirical data to develop interventions, which we've been able to do. And that's very exciting. So hopefully that provides some interesting lessons for you in the audience. So I think it was advertised that I'm going to talk about how empirical research informed a health literacy construct, how we then use that data to develop jail-based programming, health education, and then sort of built from there. We took something we did in person 1,000 years ago, pre-pandemic, and then moved it to an mHealth platform, which is web-based, coincidentally during the pandemic. So that worked out really well. And then of course had to respond, and as many of us did, to the pandemic and pivot to COVID from sexual health and cancer prevention, which is where I was working. So I'm going to talk in this presentation about serving women who are involved in the criminal legal system. And I've sort of dropped the word justice from criminal justice because the system is not that just for many, many people, if you know anything about the system of mass incarceration in this country. And then I also talk about women because most of the people in our studies identify as women, with just a couple of exceptions. But for the most part, we're serving people who do identify as women. We're certainly working harder to try to be better about language and inclusiveness in our research. So speaking of mass incarceration, the US incarcerates more women than most any other country in the world. There are 7 million people under some type of criminal legal supervision in this country on any given day, 2 million people who are actually behind bars, 13 million people pass through a jail or a prison each year in the US. And the difference between jails and prisons is that prisons are long-term facilities where you get sent if you've been sentenced, and jails, where I do most of my work, are community-based carceral systems where you are either awaiting sentencing, trial, or have been sentenced to a year or less. And jails are really interesting from a public health perspective. I'm a public health researcher because there's lots of community turnover. People are going sort of in and out, 24 hours, a couple of weeks, a couple of months, and then they're back out into the community. So it's sort of an interesting space in which to work. With respect to the population that I work with, there are 1 million American women under some sort of criminal legal supervision on any given day. And while there are certainly more men than women who are incarcerated, there has been a 600% increase in the incarceration of women since President Nixon waged the war on drugs in the 70s. As I'm sure you know, there are pretty significant race disparities in terms of who we incarcerate. The rate of incarceration for Black women is 6 times that of white women. Only half of people who are incarcerated have a high school education, and between 1% and 40% have employment before incarceration, with women significantly less likely to have stable employment before they get incarcerated. The war on drugs has had a unique impact on women, and women of color in particular. So because I work in the health space, it is impossible to ignore the health disparities that people face when it comes to the folks who get involved in the criminal legal system. The rates of substance abuse, in addition to infectious disease, are high. Drug problems among people who get incarcerated are sort of a normative experience, as are mental health problems. We say that the New York, Chicago, and LA County jails are the largest mental health facilities in the country. Between 60 and 90% of the women we work with have a comorbid substance use mental health problem diagnosis. This slide represents serious mental illness. Now, I work specifically in cancer prevention, and so was primarily a sexual health researcher, and to some degree still do sexual and reproductive health work, and was very smart. When I got my first faculty job, I was at a place with a big cancer center and thought, how can I parlay this interest in sexual health into something that I can get money for? And the way to do that was to focus on cervical cancer. So I was looking for a health disparity problem that was unique and underexplored. And as it turns out, for the last 40 years, women who have an incarceration history are 4 to 5 times as likely to have cervical cancer compared to women who don't have such a history. And for those of you in the audience who are inspired by this cancer prevention angle, the rates of liver and lung cancer are also very high, and very few people are actually working in this area to address those health disparities. So I invite you to work with us. The factors that drive cancer disparities among this population have to do with high rates of smoking, which we know is a cancer-causing practice, high rates of alcohol problem use, and then infectious diseases that are related to cancer. Have I just frozen? Okay, I'm back. Sorry, my picture froze in the corner. And then, of course, these sort of behavioral issues are made even more acute because of the social determinants of health that people who find themselves in the criminal legal system also face: poverty, racism, homelessness, all of the sort of structural factors that make cancer prevention difficult. And I also work in non-Medicaid expansion states. So only half of the women I work with in Kansas and Missouri have health insurance, which further complicates their ability to get cancer screening, but in particular, follow-up care. Okay, so this is my lovely team. It's an old picture, but I invite you to check out our website to find new pictures of the team. And we have been working to address this cervical health disparity in particular for the last 13 years. And our mission is to empower people in confinement to protect their health, create opportunities for health promotion on the outside, and really think about linking community health systems that promote cancer prevention and health for this high-risk group. And we work primarily in Kansas City, which straddles a state line in Kansas and Missouri, but we also have ongoing studies in Birmingham, Alabama, and Oakland, California. So these are the 3 jails we work at in Kansas City, and it's a metropolitan area, so we work in these different sort of community contexts. And this is the fun empirical parts. Okay, so as I said, I showed up to Kansas City 13 years ago, and with my partner, Pat Kelly, decided we're just going to get in jails and we're going to talk to people, because there was really nothing that had been done in our city, or not very much that had been done. So in the span of 4 months, we interviewed 600 people at those 3 jails about their health needs, about their health service use. And I got a little money from our cancer center, as I hypothesized I would, because cancer is a big deal in terms of our research program, to sort of study women's cancer screening and follow-up. And I found a couple of interesting things. One, that for the most part, women were getting screened. About 70% were up to date with their Pap tests. That 40% had an abnormal Pap history, which was pretty high, given that only 6% of all Pap tests are abnormal in the US. And that the most important thing was that 15% of women said they got their last Pap test in an emergency department. So this was the first signal to me that there was a health literacy problem. You can't get cancer screening in an emergency department. What you get is pelvic exams for abdominal pain, bleeding, STDs, but you don't get cancer screening. And so I sort of had a clue, okay, women are sort of misunderstanding, the difference between a pelvic and a cancer screening exam, this Pap test. And so at the same time, got a little more money to start talking to women. So this was a qualitative study, the paper with my favorite title ever, because the women are right. The vagina is a very tricky little thing down there. And so we talked to women about their last Pap experience, about their last abnormal Pap follow-up experience. And then we also looked in their medical chart to see if women were understanding one thing, but that clinicians were documenting a different set of things that were happening in the encounter, to see if there really was a health literacy problem. And over the span of 2 weeks, I printed out all of the transcripts from this study, had them in a manila folder, used the old highlighter method, and wrote codes for the data. I was using an open coding process right in the margins of the manila folder. And the data sort of hung together in 4 categories. The first was sort of varying levels of knowledge about what a Pap test is, what a pelvic exam is, what's the difference. The second area was around beliefs about screening and cancer prevention. So this, idea that, I get an annual exam, and on my birthday, I remember to go to the doctor and get my cancer screening test, or, if it ain't broke, I'm not going to fix it, because sometimes you can't feel cervical cancer. Right. So these were sort of the beliefs women had about screening. Their, the extent to which they would have inherited cancer from a family member versus, of course, as we know, cervical cancer is caused by the HPV virus, which is sexually transmitted. And then the sort of third area was around women's self-efficacy for cancer screening. So the women we work with are juggling a range of issues around reconnecting to children, reconnecting to partners, homelessness, mental health problems, drug use. That cancer prevention is sort of the least of their concerns. And so how do women have the sort of self-efficacy to get screened and to follow up? And then the fourth domain was confidence navigating health systems despite stigma. So the word on the street in our community, and I'm sure it's the word on the street in your community, is that there are some hospitals that are better than others, some providers that are better than others when it comes to dealing with your criminal legal history. And so we have a hospital in our town that has a state police force on staff, and that people would tell us that folks were looking up their records as they walked into the hospital, and that if you went to our hospital, this was a place you might get arrested. And so we were really interested in hearing from the women, well, where else do you go? And of course, the women had a bunch of different hacks they use, where to take their kids, where they go themselves to avoid getting picked up in a healthcare setting. So when we were looking at those 4 domains, knowledge, beliefs, self-efficacy, and confidence navigating health systems, it really looked like a cervical health literacy construct. And that was the basis of my first sort of intervention. Here are the sort of topics that we ended up operationalizing, right, as sort of constructs of health literacy. And I talked about knowledge, belief, self-efficacy, and confidence. And this is essentially what we covered in the intervention. And when I was applying for money to fund this health education program, I had a great program officer at the National Cancer Institute who said, you need to check out the Institute of Medicine report on health literacy. It is called Health Literacy, A Prescription to End Confusion. It's an old report. It was published in 2004. But the report really sort of defines health literacy and is a call to the field for more interventions that address health literacy specifically. And I got to tell you, after having worked in this field a long time, there's still not a lot of interventions like this that specifically address disease-focused health literacy. And that's really what we've done, is focused on cervical cancer health literacy. Okay, so here's Sweet Molly, one of my research assistants who now is finishing vet school. That was her passion in one of the jails in which we worked. Okay, so we did the intervention and it was effective. So over the course of the intervention, over the course of 3 years, we boosted women's health literacy, and health literacy levels sort of plateaued over the 3 years of follow-up, so that, you know, you can build people's health literacy. But perhaps most importantly, that a year after the intervention, women were more likely to be up to date on their PAP tests, and that correlated with high levels of health literacy. So the intervention worked. So what do you do when you have an intervention that works? Hopefully you make more health literacy interventions, and that's what we did. We also found while we were doing the intervention in the jails, so we implemented that cervical health literacy program over 2 years with a little under 200 women, 29 week-long sessions. And we found 2 things. Number one, not surprisingly, women don't think about their cancer prevention in a silo. They think about women's health more broadly, like where does cervical cancer screening fit into broader discussions about reproductive goal planning, STD prevention, for example. The second thing we found was that most of our women have cell phones, and not just cell phones, but smartphones. They have Facebook handles, they're on Instagram, they're on Twitter. So there are lots of opportunities for connecting with women in the community, and we followed our women into the community. So we've been with this cohort of women. We're now with 108 of the original 188 for 8 years. So we have these long-term relationships with women, this lovely team right here of 4 ladies. And we found that a good way to keep up with them is finding them on Facebook or using their cell phones. And of course, their phone numbers change, but we've sort of found a way to have the women check in with us. We pay them every quarter if they call us and check in and update their contact information. And so we thought for this next sort of group of health literacy interventions, we would make it be sort of holistic women's health. So we address 4 domains: cervical cancer prevention, STD prevention, breast cancer prevention, and reproductive goal planning. All of this is funded by the National Cancer Institute, so it has to have a strong cancer focus, which it does. And then secondly, we move the intervention to the web. Now, this was very fortuitous because pretty much as soon as we developed the intervention, the pandemic hit. And so I haven't seen the inside of a jail in 3 years. We just, we couldn't go back to jails. And so the timing was great to be able to implement a program with people that used web technology. And so that's what we did. And that's what we're doing. We're actually almost done with this randomized trial. I think we are at about 197 participants, and we'll stop somewhere between 200 and 220. So we're almost done implementing this program. And I believe I can show you what it looks like. So it is a web-based module. If you go to, I don't think I have the website here, but I can type it in the chat later. It's shewomen.org, www.shewomen.org. And you can see our women's health module, and we have a new COVID module. And we use a mix of text, right? So this is what a PAP test is. And we use a mix of video. And with the videos, we do a couple of things. And we're really trying to replicate the benefit of doing in-person interventions, right? Where you have rapport, where you have dialogue, where you get at people's misperceptions. So I'm going to show you a couple of examples. So here is just a knowledge video about what is a PAP test.
What is a PAP test? A PAP test is usually done during a pelvic exam. Remember, this is not a test for cancer. It is a test to prevent cancer. During the exam, The healthcare provider uses a special soft brush to collect cells from your cervix, the lower, narrow end of your uterus that's at the top of your vagina. It's quick. It takes less than 1 minute. The test is sent to a laboratory where they look for HPV and changes in the cells that can mean pre-cancer.
Okay, yeah, I think you get the idea. So that is Aisha. She is sort of our narrator, our recurring character in these stories that gives you the sort of nuts and bolts, the knowledge pieces. But then we also wanted to use a mix of, both sort of knowledge pieces, but also the storytelling to get at people's beliefs and self-efficacy. And so here is an example from the STD module of that approach.
Condoms. Roll 1, take 6.
Are you clean?
I've been checked for HIV, hepatitis B and C, and the clap, but not for like herpes and genital warts. They say those don't show up in dudes anyway.
But when? When was the last time you went to the doctor?
Last time I switched girlfriends,
And when was that? Were you even faithful to your last girlfriend?
do I have to answer that?
Don't lie to me.
I mean, for the most part. Were you 100% faithful to your last man?
I really think we need to go get checked together if we're going to be having sex. We either need to use a condom or just wait until we both know.
Why? You don't trust me? I'm telling you, I'm clean.
It's not that I don't trust you. It's that you could be carrying something that doesn't have symptoms in men, like chlamydia or gonorrhea, and even HPV, which may be harmless for you, but it could cause cancer for me.
All right, babe. But I don't have no condoms with me. So we can use them next time.
I have some condoms right here.
So these are not professional actors. Despite big NIH money, we felt like we were operating on a shoestring budget. So those are just members of the team. I star in some videos too, which I'm happy to show you. And I think, as promised, we do a couple of things in that video. We try to hit on people's beliefs about condom use. We try to hit on self-efficacy for negotiating condoms. We do the empowerment stuff where we show Joy's character, carrying her own condoms, a whole strip of them. And so that is really sort of the flavor of this intervention. Women can move through the modules. This whole intervention, the 4 sessions, I think takes 2 hours to finish. And women don't have to finish it in one go. They can come back to it. And so, I think 197 women have already completed this. And I'll be able to share efficacy results soon, hopefully. Okay. So then, we're going along and the pandemic has hit. We have stay-at-home orders. And like I'm sure everyone else on this call, the question becomes, oh my gosh, how do we respond to the pandemic? What is our role as public health people and people who are working in nursing and medicine? Where are our participants? What is happening to the women? As I said, we've been with these women for 8 years now. So we had developed pretty serious relationships with the participants. How are they doing? We're all struggling. Are they struggling? And just as we were concerned about our participants, they were concerned about us. We started getting calls. And I mentioned we were in 3 sites with another study at this point. I have this other study in Oakland, Birmingham, and Kansas City comparing how women navigate cancer screening given different sort of health policy contexts, non-Medicaid expansion versus Medicaid expansion states. And so we started getting calls at each of the 3 sites. Oh my God, how are you? How are your kids? Are they out of school? We started calling people. Are you able to socially distance? What's going on with work? Do you still have work? And so just, started doing really quick and dirty research about, how people were coping, how the most marginalized people in our society were coping given this pandemic. And then the vaccine becomes available, which is this great thing, but we collected a little bit of data from our women and found that only about half intended to get vaccinated. And only about half of our women are vaccinated at this point of looking at the data. And so we started to collect information about their sort of vast beliefs around hesitancy and efficacy. And like many Americans are sort of all over the map, right? They get information from all sorts of sources. They trust some sources over others. They're exposed to a fair amount of misinformation. They pass information through informal channels. And so it really looked like, and also have varying levels of beliefs, varying levels of knowledge about the efficacy of the vaccine, varying levels of beliefs about what to do for mitigation for COVID. And it started to look a lot like COVID-specific health literacy. So in the pandemic, after a vaccine was available, we got more money as part of the RADx Up NIH initiative. So this was a congressional approval of money to look at COVID testing. And so we were able to build women's COVID testing and vaccine literacy in a post-vaccine world. And so we are implementing this new health literacy program now. And there's Aisha, our friend from the Women's Health Intervention, who's back for COVID. And I'm going to show you a couple clips. I hope the videos are exciting to you because I really do think that they illustrate the approach that we're trying to use here. Okay, my mouse has done something weird. I'm almost done with the presentation. That's the good news. But my mouse has decided not to work. Hold on. Let's see. Okay, there's my mouse. Sorry, everybody. Okay, here is Aisha. So this is the nuts and bolts information.
Welcome. I am your guide in this journey where we will talk about COVID-19. You can call me the Animated Information Support Hostess Avatar, or for short, Aisha. Together, we will explore our current knowledge of COVID-19 and learn how we can protect ourselves and those we care about from becoming sick. We will discover what to do if we get infected and learn about the disease's potential long-term consequences. With the help of my friends, Linda and Marla, we will talk about real experiences with the illness from different perspectives and find out how to search for and be critical of information about the pandemic. To keep things interesting, we will combine animations with videos and add a few quizzes along the way. But enough of this introduction. I know you are looking forward to the experience. So let's begin.
So in these mHealth interventions, I partnered with a friend and colleague who's a journalism and communications professor. And so Mughar is sort of up to date on the literature about how to reach people in an mHealth context with information that might motivate behavior change. So that's the assumption we're working on, that if we can develop content-specific health literacy, health domain-specific health literacy. So for example, this is around COVID, that we can use health communication strategies to sort of change people's behavior, get them into testing, get them into vaccine. And as I said, in order to address people's beliefs in self-efficacy, we really want to tap into sort of, how people have relationships. So we did hire professional actors here. The RADx budget was a little bit bigger. And we adopted a telenovela model. So it's actually fairly compelling if you see the whole intervention series, because you want to know what happens to these characters, because you see the same characters and it's sort of a story that builds. And here is one of those little segments. This is about where people get COVID information.
In the previous episode, Linda and Marla discussed some myths surrounding COVID and its prevention and treatment. While less concerned now with some of her issues about COVID, Marla is still worried about pushback from family and friends. With all the information out there, she wonders how to figure out which to believe.
You sure trust this science stuff. Listening to you makes sense, but some of my family and friends would disagree and argue the opposite of your views. I'm afraid of what they will say. How do I know what to believe? How do I know what's the best decision for me?
Marla, I can't tell you what to think or how to think. That's entirely up to you. I can, though, provide the facts that I know are true, not because I say so, but because they are backed by sound evidence. That means that they reflect the experience of thousands of people, not a few cases. A lot of the information on these anti-COVID vaccine websites are designed to instill fear, and that's because they often have a hidden agenda. We had a speaker come to the hospital, and she told us about some tips on how to identify trusted sources of information. These tips are valid for everything online, not only COVID-related websites. Let me share these with you.
I never heard about something like this. What did you learn?
First, look at who's providing the information. Is it a serious institution that's been around for some time and has a track record of delivering reputable information? Something like your local health.
Okay, so that gets at self-efficacy. It provides women resources. An important part of critical media literacy, for example, I was a journalism major back in the day, so we studied media literacy, is how to appraise information that's accurate versus not. And misinformation has become a huge issue in these pandemic times. We try to hit on all of these constructs. And if you're wondering sort of how we ended up with these videos, we went through a process of initially, going to our empirical data, seeing what emerged, deciding here are the points we need to hit, looking at the literature to see, well, what is the sort of evidence base of information we need to hit? And then a group of experts wrote scripts. And then with our communications professor, started editing the scripts so that they would be a little bit more easier to understand, that the readability wouldn't be so high, that they would reach a general audience. And then we piloted with participants. So when we piloted that segment with participants, one of our participants said, and she used more 4-letter words that I'm going to use. She said, forget those women. If they don't want the right information, don't tell them anything. She was like, screaming at the iPad because she was so enraged that if you're trying to share information and your friends are still going to judge you anyway, then forget them. They don't need the information anyway, which of course I thought was great because that is exactly the kind of response we wanted to elicit. We wanted women to watch the telenovela and have a real strong reaction. And so we'll see. This study, I think only 16 out of the 400 people have been enrolled. And so we'll see if these are effective intervention strategies and health communication strategies. Okay, I'm almost done talking. All right, so in conclusion, I think, as a researcher and probably as a practitioner too, starting with a health disparity problem is really critical. What is the problem you really want to address? And then sort of, this is an old researcher trick. You kind of articulate what is known in the field and what remains to be known. When it came to cervical cancer among women in the criminal legal system, almost nothing was known except that there was a disparity. We didn't know what drove that disparity. We didn't have a lot of interventions to address that disparity. And so I was able to use empirical research to develop interventions. Now, as I'm sure all of the public health people in this audience know, you have to also be a bit flexible and respond to public health emergencies. And what's so great about a health literacy construct is that it can be adapted to address any number of health issues. So we were able to quickly pivot using the same sort of understanding about what health literacy is in the population to move from one disease to the next. So now we're covering cervical cancer, breast, STDs, reproductive goal planning, COVID testing, and COVID vaccine, using essentially the same model. And so that you can develop interventions quickly, you can capitalize on the way in which people are using technology, the way in which people are interacting with the world around them. And over the course of my career, it really feels like what I'm doing is working in the space of critical health literacy, which is to talk to people, to treat them as the experts of their own lives, and that, that they really know what's going on. They really know what the best strategies are around a health problem, and to really step in as people with maybe some specific evidence-based information that can help them kind of navigate systems to do the things they need to do to protect their health. So the way I think about critical health literacy is that it's through people's own storytelling that you discover domain-specific health literacy. And you can foster a discourse where people can come up with their own solutions. And that is really the spirit in which I have been working and try to work. And so the last thing I'll show you is that we've really been interested in storytelling on my team. Just for fun, Last year, we decided to shoot some documentary film because we thought who better to tell stories than the women themselves. And one of those films will be featured in Boston in a couple of weeks at the APHA Film Festival. These are all student edited films. So this is where the students come in. I mean, the students have been part of my work this entire time. And we taught the students how to edit film. And so we have a series, if you scan that QR code, of documentary shorts that students wrote and edited. And it's, you know, it's not health literacy necessarily, but it is a way to sort of harness the power of storytelling, people's own understandings of their health and social circumstances to advance the field. So thank you so much. I will take questions. I'm going to leave this up for another second in case anyone wants to scan the QR code.
Thank you so much, Megha, Dr. Ramaswamy. There have been various questions that have come in, but let me just start by saying it's really nice to hear the arc of your trajectory here, and I'm sure that there's like lots of directions you could go in, but you took us through the path with it. You know, one question some people wanted to know. And I think that we could also allow people to be unmuted if they wanted to speak for themselves. So maybe in the behind the scenes, Mario, if you could, it looks like Cindy Brock might have a question or two to ask, if you could allow her to do so. But in the meantime, people wanted to know a little more about the videos. Are they able to see them or use them, or how do they do that?
So first of all, I'm just seeing that the volume was low. I'm so sorry. Is the volume still too low?
Most of the time, it's been perfectly fine.
Okay.
Yeah, absolutely.
I apologize for that. I just now saw that.
Yeah.
So the videos, because they're still being tested, are not publicly available. However, if you send me an email, I can, you know, make some of the videos accessible. The moment we have efficacy data, which will be in the next month for the women's health intervention, I will make all of that publicly available. The COVID one might take just a little bit longer because we want to be spreading information that's not useful.
Sure. Yeah. You have this kind of longitudinal cord, the 180 or so that now continue to follow with you. That's kind of what you mentioned, paying them quarterly. How much? How's that work? How much? Yeah.
Yeah, we pay the women pretty good money. And the reason we do it is because we value people's time. I've mentored hundreds of students. I do not believe in unpaid internships. And I do not believe in spending 2 hours with people and not compensating them for their time. So that's sort of one thing. The other thing is, as I said, our women are so underemployed. And when they do get money, it is for things that are sometimes illegal, sometimes under the table, sometimes that they don't want to be doing. And so we feel like if we can pay a woman, you know, $50 for a survey, which is how much we pay, $10 for a quarterly check-in, that is certainly, you know, worth doing. The other thing is we found that there's sort of a sweet spot in terms of getting women to call us. And it is $50. $20 is not enough. $30 is not enough for an annual survey. $50 seems to do the trick. And the $10 quarterly check-ins are both valued and enough. Our friends in San Francisco for the quarterly check-ins give socks because San Francisco is cold year round. And socks, warm socks are sometimes enough.
Yes, it's astonishing and painful to get your head around exactly what that means, but that's how a lot of people are living. I've been told that if you do want to ask your own question with your own voice, which is preferable, if you would raise your hand, Mario can unmute you in particular. So if someone wants to specifically raise their hand, then that's how you do it. Mario can unmute you. There you go. Cindy's raised her hand, Mario.
Yes, and he's unmuted me.
Oh, fantastic.
Shall I go ahead?
Please, yes.
Hi, this is Cindy Brock. I'm with the Agency for Healthcare Research and Quality, which is part of the U.S. Department of Health and Human Services. and have attended a HARC, I believe, all 14 years and been a supporter. Fantastic work that you're sharing with us. Just so excited to hear about the qualitative work. So I'd sort of two lines of questioning in my head. One is about health, the definition of health literacy and the nature of your interventions. So the first intervention that you were talking about in terms of cervical cancer seems like it might be increasing knowledge. And there have been lots of sort of, cervical cancer, health literacy, measures and all sorts of specific topics. But there's also discussion in the field that this isn't really health literacy in terms of the skills that we speak of with health literacy. So I was wondering if you could sort of address that dichotomy between trying to give them specific kinds of knowledge and trying to increase their skills. And then in the second study that you talked about, you mentioned that you were trying to teach them the skill of appraising, is this information that I can depend on? Is it trustworthy? And how are you actually measuring whether they're then able to apply that skill? So that's a whole bunch.
So we're doing it pretty clumsily, but we're learning as we go. And I think, for the first intervention, it's increasing women's knowledge, changing their beliefs around screening such that, they no longer understand cervical cancer as being something that's passed down from one family member to the next, but understand it as caused primarily by HPV. And I do appreciate the comment that HPV is now going to cause more cancers in other parts of the body than the cervix. I think we're already there. And that we do try to impart skills around self-efficacy. Where is the best place to go? How do you get low-cost screening and follow-up if you don't have health insurance? Where can you go to the health system without being sort of reported to the police or arrested? So there is some sort of skill building there. And, I think like many researchers, we look for standardized instruments that allow us to sort of measure what these constructs look like. And so in some of our evaluation papers for that first intervention, we show in the areas of knowledge, understanding the severity of the disease, understanding susceptibility to the disease, that's beliefs, building self-efficacy, that we're able to move women using measures on each of those 4 domains. And then with the COVID intervention that you saw, I think that's where you start to see, okay, we're trying to teach the skill of appraising information. Again, we use standardized instruments and they're not great. I think we may actually measure, do we teach women to appraise information critically for COVID using like 2 questions that maybe we made up. So it's not great. It's a bit clumsy, but we are, the overall goal of that COVID grant was really, are women getting into testing and what does uptake of vaccine look like? And everything else is sort of a secondary measure. So we look in the field to see if there are instruments that will help us, that have been tested, that will help us measure these constructs. But it is true that it's a bit clumsy, and sometimes we're just doing the work and maybe not measuring it appropriately because the study wasn't, sort of designed with the primary outcome of changing people's ability to evaluate information online. Does that help?
That's great. I wanted to point out another thing that Cindy had said earlier on, which was that it's fantastic and not always easy to do to get funding for qualitative work, and figuring out how to do that is a certain type of qualitative investigator jujitsu that's required to figure out how to make it work. It's not always so easy, but you were linked to an important problem and figured out how to tell that story in a compelling enough way. So that's fantastic. A few people have asked about your email. It's actually, you posted it in the chat as opposed to in the Q&A side in the chat. Now the slides are going to be available. Some people have asked about that. One question that came up, Megha, if you will, is your thoughts about maybe the transferability of skills that you're talking about here into other domains for people's lives?
Sorry, I was typing while you asked that question. Can you say it once more?
Sure. There's a question that came up is kind of your sense of the transferability of the skills that you're working with people on, for this purpose into other domains of potential empowerment in their lives.
Yeah, I mean, I think, right, knowledge is power, and we certainly try to work in the spirit of, I know cancer doesn't probably matter to you, right? Given the vast number of things that you have to deal with right now. But, could we impart skills around how to talk to your clinician, how to advocate for yourself, how to ask questions during an encounter? So one of the things that came up was, and it's not just women in this population, it's a lot of people. A clinician doesn't tell you when they're swabbing for cancer cells versus when they're swabbing for STDs. And so how to get in the practice of asking the question, right? Like, what are you swabbing for?
Well, but even if they did, this is not like, there's plenty of distractions in that scene. Like, this is actually not the easiest place. There are a lot of times that different types of clinicians may even be trying to communicate, but this is not the easiest moment to be learning new concepts. And
no, but I think, like, for the patient, I think what we're trying to impart is just the ability that you can be an advocate for yourself and that you can ask questions. That's that critical health literacy component. Like, can you be a critical consumer of information, regardless of who that information comes from, whether it's the internet or a nurse or anyone else who you encounter?
I absolutely agree. And I would say that it's actually quite critical to have an empowerment focus in many aspects of care, but like certainly, when a person's about to have a pelvic exam, they should feel empowered. Like, the primary thing is, like, if it hurts, you should say something. So to engage in cognitive tasks in that moment is also tricky. So oh, well, how many vaccinations, there's a lot of, it's also kind of mysterious. The idea that you could have a vaccine that could protect you from cancer is kind of like magic.
It is. And so we're working in that area. If you go to shewomen.org, and as soon as we have efficacy results, all of this will be made publicly available, as a result of the funding. The goal that NIH wants you to make it publicly available. You'll see an HPV vaccine module. So we're working in the area of HPV vaccine catch up. Now the FDA has approved it up to age 45. This is a high risk group. And so to sort of teach women how to talk to providers about, okay, this is why I want the vaccine. Where can I get it? If I don't have insurance, how to pay for it. But you brought up this issue of, if it hurts, say something. The other issue that our women face is that, some 2/3 have a history of physical and sexual abuse. So long trauma histories. And so I think pelvic exams can be very difficult for all women, but perhaps especially for women with a trauma history. And so, how can women talk to their provider about, I feel very uncomfortable, can there be another person in the room, et cetera, et cetera. Those are the kinds of, I think, transferable skills we hope to impart. Also, what is the best clinician in town? Kansas City is a small community, as I'm sure Boston is, right? Like, there are some hospitals with a better reputation than others. And that's how our community works anyway. Better reputation in terms of treating people. And so can women use that knowledge to find the best place to get care in a setting that they feel the most comfortable? Yes,
but that does link to another question that came up, which had to do with language. So I don't know about the linguistic diversity of your population there, but or your activities in other languages maybe.
Yeah, so there is linguistic diversity in Kansas City. Happily, non-English speakers are not getting wrapped up in the criminal legal system in Kansas City yet. And so I think about 10% of our population is Latinx, and they're all mostly English speakers. So we have not translated, but if someone wants to do that and ask for money to reach a Spanish speaking or some other language speaking population, I do believe in sharing. I'm happy to give materials over if someone is interested in doing that work. but we have not prepared it. I put my email again in the chat. And then there's another question here. Oh yeah, great video. Keep in mind, HPV causes other cancers. Yeah, I think they're, the other area I'm interested in is getting HPV vaccine for PrEP users and people in HIV care. So certainly it's an important space to work. There's not a lot of great HPV literacy information or interventions out there. Are women getting cancer screenings in prisons or at release? Okay, so as I said, I think at the beginning, there's a difference between prisons and jails. Prisons are long-term facilities, and you can get cancer screening and, you know, sort of regular healthcare in longer term facilities like prisons. In jails, however, which are these short-term facilities, I did a survey in our 4 states, Missouri, Kansas, Iowa, and Nebraska, and I think only 6% of jails were offering cervical cancer screening. These are not facilities, short-term facilities that do prevention. They will treat symptomatically, but it is really up to people to learn how to advocate for screening and have the wherewithal to get routine screening once they get into the community. I hope that it helps explain the patient group. And thank you for this resource from AHRQ. Oh, you know why no one is seeing my email or any of my messages? Because I'm sending it to the host. Sorry.
Oh, I'm sorry. I should have noticed that. You're only sending it to.
All right. So this is a sample grant. If anyone wants to see how to write about qualitative methods to get NIH money, this is pretty much how I always do it. I'm also happy to send you other funded grant applications if you email me. And then I'll type my email here to everyone as well. I am so sorry.
I got it.
Okay.
Great. Well, thank you for kicking us off here. And I don't see other hands raised, but
oh, great. Okay. Awesome.
Yeah. And I'm very happy that you brought up many of the topics that you brought up, but one of them is just the space of the carceral system. I mentioned this before when we were talking. You mentioned that maybe half of the people that you're engaged with, come into the system without a high school diploma, and one of the painful phenomena of the carceral system and education in the United States is that in each state in the country, it is the largest provider of adult basic education services, which is kind of overwhelming, and it gets back to this massive intersection between the themes here between access to education and health literacy and the carceral system. There's just this massive overlay. I think there's just, it's great to hear about your work, but I would say that there's probably a massive array of opportunities for people if they would be interested in learning about how to do work in the carceral system.
So a couple of things. We have some great videos about how to do work on the carceral system that I'll try to quickly find for you. But the other thing is, because of sort of the low rate of high school education, we had a reviewer suggest to us to use a standard health literacy assessment just to see where our women were. So we used the STOFLA, which is some standardized health literacy tool.
Yes, we know.
90% of our women endorsed high on the STOFLA, suggesting that they have pretty high levels of health literacy, regardless of high school education. And that's really why the sort of domain-specific health literacy became so interesting, because, the women should have high health literacy. But, it was sort of varied when you drill down to sort of specific health areas.
Yeah.
Do I have time to answer this question about are
Sure.
the women connected to each other? So they are. I mean, as I said, Kansas City ends up being a small town, and many of our women sell sex. Officially, about a quarter of the participants said they did, but probably more do. And we've definitely had the situation where one of our participants, was sort of the mother figure and would take care of women in the streets. And so several of the women lived together. They shared mailboxes. We have this great paper about sharing information and sharing resources. that one of our nursing faculty wrote. I'm going to try really quickly to stop talking and post those 2 resources.
No, it gets to, the topic of the critical appraisal is like trusted sources.
Yes.
And there will be people who have their own trusted sources, that they have their own networks of relationships that provide trusted sources, and figuring out with people, what are the things that, how do they get information that they do trust, is actually part of the puzzle in this space.
Yeah. And I mean, we always say that you are the expert of your own lives. Tell us what this looks like. It's completely a harm reduction approach, and what makes sense for you in your context.
Yeah, fantastic. So I think it'd be great to blossom, to grow health literacy research in jails and prisons and around the country. I think there's a tremendous amount of opportunity, so I'm happy that you brought the theme to the group. There's going to be some of us will be make your own adventure, because a lot of these things will be like new, but that's okay. There's like a lot that makes actually, room for success and improvement and growth. Great. So there's several resources that Dr. Almasami had put into the chat to everyone now, and so thank you again. Everybody, please remember that each session during today and tomorrow is its own Zoom link. So you have to go back to the main live event page and click on the next link. You do have a question here, maybe in your last minute or so, about juvenile detention.
So I got my start in New York City with teenagers who get incarcerated as adults in New York City. So there is a body of research on kids who get incarcerated. And the needs are a little bit different, but not always. I think foster care issues become really important. Kids aging out of the system, where do they go? When I was doing that research, the 2 most important indicators of success were, do you have housing? And do you have health insurance? And so if those 2 things are in place, any number of positive things could happen for a kid. So.
Great. Okay. Well, congratulations to us for having you speak. And I feel like I'm going to be reconnected with you because now that I'm at Tufts and you have these connections with Elise Wirsel, and so it'll all work out.
Yep.
All right.
Great. You have
be well. Yeah. All right. Be well, everybody. And I'll see you in another Zoom room coming soon. Bye.
Thank you.